Good morning, one and all. I am Dr. Vigneshwaran, Professor of Medicine from Chettinad Academy of Research and Education. In this lecture series on ECGs, we are going to see what electrolyte abnormalities can do on ECG. So, the objectives of my talk will be, first we will see what are the electrolyte abnormalities that cause ECG changes. Then we will see how do these electrolyte abnormalities, how they cause these ECG changes. Then we will see what are the ECG changes that occur with these electrolyte abnormalities. Then we will see what are the causes of these electrolyte abnormalities, and then we will see some case scenarios so that we understand this slightly more better. So, to start, first is what are the electrolyte abnormalities that cause ECG changes. Normally, there are a lot of electrolytes we measure in the serum, like sodium, potassium, chloride, bicarbonate, calcium, magnesium and phosphate. As we can see the values, we have a normal levels for each of these electrolytes, and as we see, all of them are in a very narrow range. Of the electrolytes, what I have marked with, we made it bold and italic, are the two electrolytes which are associated with ECG changes. So, potassium and calcium are the two electrolytes which are associated with ECG changes. And as you see, the normal potassium is 3.5 to 5 milliequivalents per liter, and the normal calcium is 9 to 11 milligram per deciliter. Now, coming to the next question, now how do these electrolytes cause these ECG changes? Now, for that we have to know a bit more in detail. We have to know what are electrolytes, and what is ion and what is an electrolyte, what are ion channels, and are ion channels present in the heart muscle? If so, what channels? And then we should understand movement of ions through these channels, how do they cause action potential changes, and then we should understand how action potential changes leads on to ECG changes. So, we know now there are two electrolytes which cause ECG changes, one is potassium and calcium. So, with that in mind, we will see what changes it causes in action potential. So, to the first point there, what are electrolytes? Electrolytes are actually minerals, and they are all charged minerals. Any charged atom is called an ion. So, electrolytes are also ions, and they are actually ions in water. There are two types of electrolytes, one is positively charged electrolyte and another is negatively charged electrolyte. Positively charged electrolytes, for example, are sodium, potassium, calcium and magnesium, and negatively charged electrolytes are chloride, bicarbonate and phosphate. To note, we are concerned about potassium and calcium, and both are positively charged electrolytes. And another point there is potassium is mainly an intracellular electrolyte, and calcium is an extracellular electrolyte. Now, second point, we have to know what are ion channels and what are the ion channels which are present in the cardiac muscle. Now, ion channels are pore forming membrane proteins. As you see, these are the ion channels, and they are present in the membrane, and they actually have help us communicate between extracellular and intracellular. So, the ions move in and out of these ion channels, and these ion channels are present in all the membranes, and movement of these ions, because of this, these are all electrically charged, movement of these ions create membrane potentials, and there are different types of membrane potential. Mainly what we are thinking is the resting membrane potential and the action potential. So, these are altered, these are mainly affected by this movement of these ion channels. Now, what are the ion channels which are present in the cardiac muscle? There are three main ion channels: sodium, potassium and calcium. Of these, sodium and calcium are only one type are present in the cardiac muscle, but there are 5 different types of potassium channels which are present in the cardiac muscle. The first, what we call it as transient outward potassium channel or KTO potassium channels, KTO channels. Then we have got IKR, which is a rapid potassium channel. Then we have got a slow potassium channel, which is IKS, and then we have got inward rectifier potassium channel, IKI, inward rectifier potassium channel, and then there is something called as ultra rapid delayed rectifier potassium channels. So, there are 5 different types of potassium channels present in the cardiac muscle, and as I told you, we are concerned with potassium and calcium. Okay. Now, the next question is how ion movements create changes in the action potential curve. Now, this is the figure showing the action potential curve of a ventricular muscle, and if you see, it has got 5 phases. First is what? It rises up. First it rises up. So, that is one phase which is called phase 0. Then it drops down. So, that is called phase 1. Then it plateaus again. It is called phase 2. And then it drops down again, which is called phase 3. And then you have a maintenance at a normal baseline, which is called as phase 4. So, these 5 phases of cardiac ventricular muscle action potential is determined by these 3 channels, which is sodium, potassium and calcium, and as I told you, we should concentrate on potassium and calcium. The phase 0, which is the rapid upstroke, which is called the depolarization, which starts from the resting membrane potential of around -90 and ascends up after it reaches a threshold, ascends up, goes above 0, that is because of the sodium channel. Now, once that you have crossed that, that is the sodium channel. Now, next is after it has reached a point, suddenly what happens, it comes down, that is called early repolarization. First part of repolarization is the phase 1. That is because sodium channels close and the potassium channels open. There are 2 potassium channels involved here, the transient outward potassium channel and the ultra rapid potassium channel. Then there is a plateau phase wherein it is maintained at around 0 degree for a long period. This is called phase 2, plateau. So, this phase is because of the calcium channel, okay, L-type calcium channel, and also some effect by the slow potassium channel. Then there is the phase 3, which is what? The late repolarization, that is the final repolarization. So, this phase 3 is because of the rapid potassium channel as well as the inward rectifier potassium channel. So, 2 channels here play a role, and then the 4th phase, which is the maintenance of the resting membrane potential, it is because of the inward rectifier potassium channel. So, what we understand is a cardiac ventricular muscle action potential curve has 5 phases: phase 0, phase 1, phase 2, which is the plateau phase, phase 3, which is the final repolarization, and phase 4, which is the resting membrane potential. And if you see, calcium plays a very important role in phase 2 and potassium plays a very important role in phase 3. This we have to keep in mind. To understand the ECG changes, we have to keep this part in mind, that is phase 2 is by calcium predominantly and phase 3 by the potassium channel. So, if you have a calcium channel abnormality, it is going to affect the phase 2, and if you have a potassium channel abnormality, it is going to affect the phase 3. If this point is clear, then we can easily interpret the ECG. Now, coming to the next question, like how action potential change is going to affect the ECG. Now, that is what we have been explaining. As I told you, the calcium channel is in phase 2, this is the phase 2 or the plateau phase, and this causes changes in the ST segment of the ECG. So, ST segment is a part of the repolarization phase, that is QRS is the depolarization, from S to the T wave full is repolarization. The plateau phase is represented in the ST segment, and that is the phase 2, and phase 3 is represented in the T wave. So, calcium channel problems are going to affect the ST segment, and potassium channels are going to affect the T waves. So, this is the important point here. Calcium abnormality is going to affect ST segment of the ECG, and potassium abnormality is going to affect the T wave. Okay. So, and you know, ST segment denotes phase 2 of repolarization, and T wave represents the phase 3. Now, we understand now that there will be ECG changes if there is abnormality with the serum calcium and potassium levels. Now, we will see what are the ECG changes which happen. Now, first we will see about potassium. Now, high potassium is called medically as hyperkalemia, and now we know the part will be involved in potassium will be the phase 3. So, that is be represented as the T wave, and low potassium is represented as hypokalemia, and that will also is going to affect the T wave. Now, what changes will be there in the T wave? In hyperkalemia you get tall tented T waves, and in hypokalemia you get a very short T wave. T wave will actually become lost. Okay, that is the important point there. Then calcium, we know calcium is going to cause abnormality with the ST segment. High calcium is medically called as hypercalcemia, and low calcium is called as hypocalcemia, and high calcium is going to affect the ST segment. So, when the ST segment is affected, it actually affects the QT interval. What do you mean by QT interval? QT interval is the time, is the area which starts from the starting of the Q to the end of the T wave. So, when the ST segment is prolonged, the QT interval is prolonged. ST segment is shortened, QT interval is shortened. So, hypercalcemia, what does it do? It shortens the QT interval, and hypocalcemia shortens the prolongs the QT interval. Now, what are the ECG changes? We will now see in detail what are the ECG changes which occur in hyperkalemia. First point is hyperkalemia. So, we know potassium has to do with T waves, and we saw hyperkalemia is high potassium, and that will affect the T wave, and you get tall tented T waves. So, if you see this ECG, the normal potassium is 3.5 to 5, and as the potassium increases to 5.5, you start to get the T wave. This is the T wave, and this is starting to become, T wave is starting to become taller. T wave is starting to become taller and tented. Then some changes also occur in the P wave, some changes occur in the PR segment, and then some changes occur in the QRS complex. And as the potassium increases, we see changes in the ECG also, very dramatical changes occur. So, we are going to see this ECG changes in an order. First, what happens is the problem will be in the T wave. So, there is narrowing and peaking of the T wave. So, this is also called as tenting of the T wave. Next, what happens is, if still potassium is becoming more and more higher, there is decrease in the amplitude of the P wave. So, P wave becomes shortened. Then there is prolongation of the PR interval. So, PR interval gradually prolongs, and if it prolongs, it becomes what is called as AV block, and it can progress from first degree to second degree, and then it can become third degree AV block. Then as the potassium further increases, it does some changes in the QRS complex. It widens the QRS complex. So, the QRS complex widens. Then what happens as the potassium still further increases, total absence of P wave, the P wave amplitude decreases very much. So, what happens, you may not be able to see the P wave at all, and this, so when P wave is not there, only QRS complex is there, it appears as a junctional rhythm, and this rhythm is called as sinoventricular rhythm. Though the rhythm starts from the sinus node, P wave is not seen. As a result, you start to see only a junctional rhythm, and so it's called as sino-ventricular rhythm. And the QRS complex then widens and it is like a sine wave. This is the mathematical sine wave, and so this is called as sine wave pattern, and in last, if it is going to become higher and higher, it is going to even produce asystole. Heart contraction stops. Heart stops in asystole. It doesn't contract at all. Now, so hyperkalemia is now clear. Okay, so potassium abnormality is going to cause T waves abnormality. Now we will go to hypokalemia. What is hypokalemia? Low potassium. So normal potassium is 3.5 to 5. Here it will be less than 3.5, and you know it is going to affect the T wave. Now what abnormality it is going to cause here? So what happens is, as the T wave, as the hypokalemia worsens, T wave, now this is the T wave, now the T wave now shortens. T wave is not seen here, it's becoming less here. So and T wave shortens and it can even invert. Okay, T wave, this is called flattening of T waves, and it can even invert. Then what happens? This is called the U wave. Normally this U wave is not seen well, but as the potassium decreases, you can start to see the U wave becoming prominent. So there is a prominence of U wave, and sometimes what you can see is the ST segment is also depressed. So these are the ECG changes in hypokalemia. The point is, potassium abnormality is going to affect the T waves. Hyperkalemia, tall tented T waves. Hypokalemia, shortening of the T wave and presence of U wave. So these are the things with potassium. Now we will see what ECG changes will occur with calcium. Now first we will see about hypercalcemia. So hypercalcemia, what we saw is there will be problems in the ST segment, phase 2 of the depolarization curve. So this is the normal ECG, and this is the ST segment. So this is a small ST segment here, and this interval is called as QT interval. So that is from the start of the Q wave to the end of the T wave. This is called the QT interval. So normal QT interval is around 440 milliseconds. Now what happens with hypercalcemia? When the calcium is high, what happens? It affects the ST segment. So what happens here? The ST segment shortens. As a result, QT interval shortens. So this is represented as, normally you have got the normal QT interval of 440 milliseconds. Now with hypercalcemia, what happens? The QT interval shortens. So the thing is, it affects the ST segment. Now in hypocalcemia, what happens in hypocalcemia? And again normal, this is the QT interval, and this is, we know, is the ST segment. So what is going to happen in hypocalcemia? The ST segment is going to be elongated, become long, and what will happen? So as a result, QT will be prolonged. So QT is prolonged above 440 milliseconds. So now we can easily remember the electrolyte abnormalities which will cause ECG changes, and we will see now what are the common causes of these electrolyte abnormalities. Okay. Now potassium we know the normal level is 3.5 to 5, and if there is above 5, so what are the causes, and if it is below 3.5, what are the possible causes? The first important cause of hyperkalemia is renal failure. So kidney is very important for excretion of potassium, and food contains lot of food contains potassium, especially fruits and juices, tender coconut water, everything contains lot of potassium, and if kidney doesn't function well, potassium is not excreted. So renal failure is an important cause of hyperkalemia. Acidosis, when body's acid is more, the pH falls below 3.5. So what happens is the acidic environment makes potassium shift from intracellular to extracellular. So the serum potassium will start to increase. Third important cause is adrenal failure. In adrenal gland, you have got a hormone called as aldosterone, and this aldosterone absorbs sodium, excretes potassium. But if there is adrenal failure, what happens? The potassium can't be excreted, so potassium level increases. Any lysis of any cell, either it is RBC or the muscle cells. So what happens? The muscles damage, so muscles release the intracellular potassium and that comes out, and that is another cause for hyperkalemia. And another common cause of hyperkalemia is usage of potassium sparing diuretics and using ACE inhibitors and angiotensin receptor blockers as antihypertensives. Commonly, ACE inhibitors and angiotensin receptor blockers are used very much in diabetic patients, diabetic hypertensive patients, cardiac failure patients, and even in renal failure patients to prevent progression of diabetic nephropathy and even other nephropathy. So these are commonly used drugs. So that can also cause hyperkalemia. And hypokalemia, what are the causes? When you vomit, when there is diarrhea, what happens? Potassium is lost in the stools, so you get low potassium. Usage of diuretics. So all the diuretics cause, especially the loop diuretics and thiazides, they cause loss of potassium in the urine, and when the aldosterone level is very high in the body. So there is something called as hyperaldosteronism. So what happens? That's aldosterone absorbs sodium, loses potassium. So that these are the causes of hypokalemia. Now coming to calcium. Calcium normal level is 9 to 11 milligram per deciliter. What are the causes where calcium can be above 11? Okay, so that's hypercalcemia. The more important cause there is hyperparathyroidism. So parathyroid is the important regulator of calcium. Parathyroid hormone absorbs calcium from the kidneys as well as from the intestine. So when the parathyroid is in excess, what happens? The calcium level increases in the body. Multiple myeloma is another cause. Multiple myeloma, see, calcium is stored in the bones. Multiple myeloma causes the osteoclast activity to be more in the bones. So what happens? From bone, lot of resorption occurs and calcium enters into the serum. Hypercalcemia of malignancy. So what happens in that malignancy? They secrete some what is called as parathyroid hormone related peptide, and this, what does it do? It acts like a parathormone and increases the calcium level. Secondaries in the bone, destruction of the bone. So what happens? Calcium starts to increase. Sarcoidosis. So sarcoidosis is a condition where there is a lot of granulomas in the body, which are what do you call as non-caseating granulomas. So these granulomas, what does it do? These macrophages produce lot of 125 dihydroxy D3. So when D3 levels are high, calcium absorption is high, so calcium increases. Thiazide diuretic is another reason for hypercalcemia. Now we'll see some causes of hypercalcemia. Pancreatitis, acute pancreatitis, what does it do? Pancreatitis means there is a lot of lipase enzyme released. So what happens? It destroys the pancreas, saponification occurs, so which requires calcium, and calcium gets deposited there. Renal failure, because kidney is the source for 125 dihydroxy D3. If it doesn't produce, what happens? So you don't get good amount of active form of vitamin D3. So calcium is not reabsorbed, so hypercalcemia occurs. Hypoparathyroidism, another reason. Vitamin D deficiency is another reason, and hyperventilation is an important reason. What happens in hyperventilation is that hyperventilation causes alkalosis. Alkalosis causes a shift in the calcium. So what happens? Ionic calcium decreases, and this is the reason for hypocalcemia. So now we have seen common causes of these electrolyte abnormalities. Now we will go to some case scenarios so that you understand this electrolyte abnormalities better. Okay. Now first case scenario, a 30-year-old female with recent bereavement in family. She has lost one of her loved ones, and she comes to the emergency room with dyspnea, breathing difficulty, and when she is breathing like that, hyperventilating, what happens is there is paresthesia, there is numbness in the peripheries, in the lips, in the tongue, in the hand, tip of the fingers, in the legs, sole of the foot, and she also has got a choking sensation, difficulty in breathing, and there is also cramping of the hands. Okay, and when the examination is done, the respiratory rate is 36, and the patient is seen to having a deep breathing. And if you see the hands, the photograph of a hand, there seems to be the hand is going for some part of a spasm. The thumb is coming inside. Okay, it comes medially. So and it is trying to get pressed here. And so this is called as carpal spasm. Carpopedal spasm is both hands and legs getting spasm like this. So, and now an ECG was taken. So what do you expect now? Okay, that is the question. Now I will show you the ECG. What is seen here is if you see anything with relation to what we know, electrolyte abnormalities is going to cause what? ST segment and T wave problems. So is there any problem with the ST segment and T wave? That is what we are going to see. Now there is one lead in the base, that is what? V5. Now it is given. Now you see the ST segment looks a bit long. Okay, all the ST segment looks a bit long. So then you know ST segment means what? It has to do with the calcium. Okay, and when ST segment is long, what happens to the QT interval? QT interval is from the start of the Q wave to the end of the T wave. So normal, I told you, is around 440 milliseconds. Now if you see this, one large square is 200 milliseconds, second is 400 milliseconds, this comes around 2, this comes around 2. So it's more than 480 or 500 milliseconds. So what is the problem here? ST segment prolonged, QT interval prolonged, and therefore the diagnosis is hypocalcemia. So hypocalcemia, in addition to these ECG changes, causes what? All the paresthesia, tingling sensation, and what is called as carpopedal spasm. It usually occurs with hyperventilation when ionic calcium is less. Now coming to the next case scenario. Now this should be easy for you. Lot of clues here. 55-year-old male who is a diabetic and hypertensive for 15 years. His glycemic control has not been very good. For the past 2 years, that means what? His glycemic control is not that good. So diabetes not good control, some organs can get affected. For the past 2 years, he has got pedal edema, facial puffiness. That means what? Facial puffiness usually comes when there is problem with the kidney, and there is also dyspnea on exertion, there is breathing difficulty. Retinal examination, fundus examination shows that there is evidence for diabetic retinopathy. So one organ is affected because of diabetes. So the eye's fundus is affected. So then his urine shows proteinuria. That means what? The kidney is also getting affected and there is loss of protein. And in addition, he is taking what? AC inhibitors for his ARBs, angiotensin receptor blockers for his hypertension. So some drugs are like that is telmisartan, all those are valsartan, losartan are examples of angiotensin receptor blockers. And if you see his examination, heart rate is only 50. So the rate is become less, and he still is hypertensive. So now what are the ECG changes expected? Straightforward, I think. We will see with what are the ECG changes. Now ECG looks very bizarre, correct? Let's focus on any one point here. Let's consider this B2. Okay, this is the rhythm strip, and we'll see the ECG here. Is there anything with the abnormal with the QRS? QRS seems big wide. In addition, what is happening is this is the T wave. Okay, now there is no gap between the T wave at all and ST. The T wave is very tall. So you are getting what is called as a tall and tented T wave. Okay, and in addition, P wave is not at all tall. P wave amplitude is very less. PR interval is okay, but QRS complex is wide. So what you are getting, what are the points you hear? Tall tented T waves, shortening of the P wave, QRS complex widening as if it is like a sine wave, and all these are classical features of hyperkalemia. Okay, so this is also a very good example to say about the electrolyte abnormality of high potassium. Now we will go to the third scenario. Now a 35-year-old female had diarrhea and vomiting for the past 3 days, and she complains of lot of tiredness and myalgia, muscle pain. Examination, she is conscious oriented, heart rate is 60, there is diffuse muscle tenderness. If you press on the muscle, there is all tenderness, and muscle power is also getting less. Okay, the muscle power is becoming less. She is not able to use her limbs properly, upper and lower limbs. The tone is less. The reflexes are decreased, mildly decreased. plantaris flexor, sensory examination is normal. So what is the ECG changes we expect? So the electrolyte abnormality we expect here will be what? Now let's see here. We'll focus on one lead. Let's consider we focus on V5. Okay. Now what is happening here? The ST segment looks depressed. We don't see a bit of T wave at all here, but what we see is U wave. So the T wave is short, U wave is prominent, and ST depression. So all are very classical to suggest what? Hypokalemia. So hope you are getting the electrolyte abnormalities and the ECG changes easily now. Now to summarize the discussion we had, electrolytes are ions and they are all maintained in a very narrow range in the body. There are three main ion channels in the heart muscle which we know: sodium, calcium and potassium. Electrolytes move in and out of these ion channels and they determine the cardiac muscle action potential. So electrolyte abnormalities cause ECG changes. The two most important electrolytes are potassium and calcium. And now we know that these two electrolytes produce distinct changes in the ECG, and they affect the action potential curve in distinct areas: calcium affecting the ST segment and potassium affecting the T wave. So calcium affecting the ST segment and potassium affecting the T wave. So T wave abnormality in hyperkalemia will be tall tented T waves. Hypokalemia, it will be that is very low voltage of T wave and even absent T wave and prominent U wave. So this is with potassium. With regards to calcium, it affects the ST segment. With low calcium, you are going to get a ST segment prolonged, QT interval prolongation. With high calcium, what you are going to get is a shortening of the ST segment and QT interval shortening. Okay. Thanks a lot. Thanks a lot for this patient hearing.